Hi everyone, welcome to your online lecture for the course Pathophysiology 2. Today's lecture covers integumentary disorders. So we're really looking at the skin in this lecture, and the skin covers, as you know, the entire body, and it is the largest organ. It accounts for about 20% of the total body weight. Now, when we combine the skin with accessory structures such as the hair, the nails, and the glands, this collectively forms the integumentary system. And the primary function of our skin, you might recall, is protecting our body from the external environment and helping maintain homeostasis by regulating such things as fluid and temperature, among other things. Here's a list of what we'll be talking about today. We'll look at both acute and chronic dermatitis, we'll look at skin infections, and then in class we're going to look at skin tumors, primarily focusing on malignant melanoma. First, let's have a really quick look at the normal anatomy of the skin, and what I'd like to remind you of is the three main layers. So the epidermis being that top layer, epi being above the dermis, which is that lower, thicker layer, and beneath that we have the sub, so sub is beneath, cutaneous is the skin, subcutaneous layer, also known as the hypodermis, also meaning below the dermis. And you can see that different structures exist within each layer. So the dermis and the subcutaneous layer, you can see the presence of all of the vasculature, and you can see within the dermis we have these hair follicles and hair shafts, as well as various glands that are present. And then the epidermis, some disorders do affect just this layer, and because it's not vascularized, it can present and be clinically different than those that affect the dermis. I'd also like to talk to you about two different important terms that will be used throughout this lecture and are very relevant to skin disorders. That's pruritus, which refers to itching, and erythema, which refers to redness. And oftentimes most skin disorders present with both pruritus as well as erythema. This slide shows us some of the names that are used to describe different lesions on the skin. So starting on the left here, lesions that are flat, they're non-palpable, they involve changes in skin color, are oftentimes referred to as either a macule or a patch, depending on the size. So a freckle, for example, would be a macule, and vitiligo would be a patch. Vitiligo is a condition where there's a change in color of the skin, affecting pigment cells or melanocytes that are destroyed in certain areas. So these affected individuals will have depigmented or really white patches of the skin throughout the body. This is a condition that Michael Jackson had. Moving on to lesions that are palpable, in other words, they're usually elevated, so they can be visually seen as elevated and they can be felt. And depending on a few different features, they can take on different names. So papules, plaques, nodules, tumors, and wheals. And we'll be using some of these terms that are listed on this slide throughout our lecture today. For in particular, papules and plaques and nodules. Of course, we've used the term tumor many times, and we will also be looking at the term vesicle. And so these are elevations of the skin formed by free fluid within a cavity within the skin layers. And the fluid that's inside can be contagious. Pustules as well we will look at, which are these cavities that are filled with pus. And so it's important to understand these terminology and roughly what they represent, because we'll be using them to describe skin conditions today. The next handful of slides will be talking about dermatitis. We'll start by looking at acute dermatitis and then proceed into chronic. And the difference between the two involves the length of time. So with acute, it's something that tends to come on rather quickly and then it goes away. So it's considered temporary. Whereas chronic is something that persists for a long period of time. If you break down this word here, we know that itis refers to inflammation, and here's the This prefix here is referring to the top layer or the second layer of skin, the dermis. So inflammation then of the dermis. And there are many different causes of dermatitis because we know the skin is such a large organ and it's exposed to the environment and it's exposed to so many different things potentially that would make it obvious that there are many different possible causes of these conditions. So we'll start with contact dermatitis, so again a form of acute dermatitis, and there are two main types of contact dermatitis, and they are allergic and irritant. So we could say allergic contact dermatitis and irritant contact dermatitis. And the name really tells you what's involved here. It's inflammation of the dermis because of contact with either an allergen or some sort of irritant. With allergic contact dermatitis, it is a common form of dermatitis that is a common form of T-cell mediated immunity or delayed hypersensitivity. And so we could classify this then as a type 4 hypersensitivity. So you might remember that with this type of hypersensitivity, there's a delayed response. And this delayed response refers to the fact that somebody can be exposed to something or in contact with something that they are allergic to, and hours later or several hours later, then the immunological response is apparent. Oftentimes, the cause of allergic dermatitis could be exposure to such allergens as latex or metals, which of course can bother some people and not others. Whereas with irritant dermatitis, acids and detergents will commonly cause, so chemicals will commonly cause a dermatitis in most people that are exposed to it, just to varying degrees depending on their sensitivity. And oftentimes the location of the dermatitis can indicate the source. So in other words, something comes into contact with the skin and then irritates it in that area. So very location specific. So in this example here, although I'm not certain, it's very possible that they had on a pair of sandals that contained chemicals that created this irritant contact dermatitis. And once the irritant or the allergen is removed, then it starts to reduce in terms of its severity and intensity. Sometimes, however, depending on the severity, corticosteroids are needed to bring down that inflammation. But because it does go away, comes on quickly and then goes away, it is an acute form of dermatitis. And you can see the distribution along here. So an area of the skin is contacted by something that irritates it or the person is allergic to, and a reaction will occur in that area. Our next example of acute dermatitis is atopic dermatitis. Atopic denotes a form of allergy in which a hypersensitivity reaction can occur not just in a specific location, but throughout really any part of the body. Atopic dermatitis is also referred to as atopic eczema. This is more commonly seen in infancy and childhood, but it can affect people throughout their life. And it kind of looks like a contact dermatitis, but remember I said that when we're using that term atopic, we're inferring that it can occur really anywhere in the body. It doesn't have to be in just one specific area. And this is a type 1 hypersensitivity. And this is something that whether you're working directly with patients or you just are around people, eczema is quite common, especially in children. And what happens with this condition is the antigen, whatever it is, generates an immune response within the body, generating a lot of IgE, which fits it into that type 1 hypersensitivity, as you might recall. A lot of times, too, this can be related to food sensitivities. And individuals that have eczema flare-ups, and they can come and go, that's why it's considered acute. Those that have these flare-ups, and if they have just regular blood work done, it might show that they have higher levels of eosinophils in their blood, which could represent and could be representative of their eczema. And so sometimes eliminating the antigen that's causing the reaction can either reduce or eliminate the eczema. but it's definitely a problem in a lot of children. On this slide, we have poison ivy dermatitis on the left, and this is a type of allergic contact dermatitis. So it tends to have that delayed immune response. And if you've ever had poison ivy or if you've ever seen somebody with it, you'll notice that it can spread to areas other than the immediate area of contact. And it can last a little bit longer than your usual acute response, but it is still considered acute because it does go away. Urticaria is also known as hives, and this is an outbreak of these swollen, pale, a little bit of redness. You can see bumps. Sometimes plaques are seen on the skin that appear suddenly, and they are either a result of the body's reaction to certain allergens, or sometimes for unknown reasons people will break out in hives. Hives usually cause itching. Of course, poison ivy as well will produce itching, or that pruritus that I spoke of earlier. And they can be, we're talking about the urticaria, it can be very widespread. And hives are a type 1 hypersensitivity, and so it creates a very exaggerated response. Seborrheic dermatitis is a chronic inflammation of the skin that can involve commonly the scalp, the eyebrows, the eyelids. It can even get into, well, the nose here at this fold. It can affect the armpits. In some cases, it can also affect the chest and the back. In infants, any of you that have worked with or will work with infants, commonly seen in infants is this condition affecting the scalp, and it's called cradle cap. It is a superficial fungal disease of the skin, and it occurs in areas where sebaceous glands are present. Remember, sebaceous glands they're exocrine glands in the skin that secrete an oily or a waxy matter called sebum, and it's there to lubricate and to waterproof the skin and the hair. Because fungi can be a common cause of this condition, antifungal topical ointments are oftentimes used to help clear it up. So that was all acute dermatitis. Now we'll talk about chronic dermatitis, and this begins as an acute dermatitis, but it doesn't go away, and it remains and remains as a chronic skin condition. We'll start with psoriasis. I'm sure this is a condition that you've all heard of, and it's a chronic, relapsing, proliferative inflammatory disorder that involves the skin, the scalp, and the nails. And it can occur at any age. And what's interesting is that a family history of psoriasis is estimated at about 60% to 90% of cases. This condition tends to involve multiple papules and that are frequently located close to joints, and there's not a lot of certainty as to why this is. So it might be the backs of the elbows or the fronts of the elbows, for example. In terms of the histology, if you were to take some of the skin that has psoriasis, it would present as this thick, scaly dermis, and there would be lymphocytic infiltration evident if viewed under a microscope. This condition also causes a reaction in the epidermis as well. And the white scaly parts that you can see are keratin, which is a skin protein that's sort of being brought into this scaly substance. It is an autoimmune disease, and that's important for you to understand that the body is attacking itself, and so a common treatment of this is immunosuppression. There's also a relatively small percentage of those with psoriasis that can develop what's called psoriatic arthritis. Systemic lupus erythematosus, or SLE, sometimes just thought of as lupus. We've introduced this a little bit already. It is an autoimmune disease. As the name suggests, it is systemic. The term lupus, I've already told you, comes from the Latin word meaning wolf, because in the past it was thought that with this butterfly type rash that shows up on the face, it kind of gives that wolf-like appearance. Now, with it being systemic, it's important to understand that it's not just affecting the skin. It can affect the heart. So as shown here in this image, the heart, the lungs, the kidneys, the joints. It can affect blood vessels as well, leading to what's referred to as Raynaud's phenomenon, which is involving very poor circulation at the distal fingers. Lupus is a type 3 hypersensitivity that involves circulating immune complex that deposit themselves into tissues. So I'll go into a little bit more detail about that now. This condition, SLE, is an immune response against nucleic acids. And so what the body does is it produces anti-nuclear antibodies, and this would be evident in the serum of these individuals. The antibodies can then form immune complexes with the nucleic acids and then deposit themselves into susceptible tissues. Again, this is what's involved with type 3 hypersensitivities, are these immune complexes that form between antibodies and antigens, and then they deposit themselves into susceptible tissues, essentially destroying them. And we spoke during urinary disorders about lupus nephritis. And that means that these immune complexes, for example, can deposit themselves into the kidneys and cause kidney problems in people with SLE. This condition is more common in young adult females. And I mentioned that butterfly rash that is also quite common with this condition. It's really it's a chronic dermatitis because it doesn't go away. And although there will be periods where it's worse than other times, it is chronic and it will remain. This person will have this condition forever. And so they'll need topical steroid creams will be very ineffective in the long term because the lesions will continue to come back. And so a systemic steroid is oftentimes used to help all areas in the body that are affected by this condition. So we've talked about the different types of dermatitis involving both acute and chronic conditions, and now we're going to move on to talking about skin infections. We'll look at bacterial infections, viral infections, and fungal infections of the skin. We'll start with acne vulgaris, or just referred to as acne, something that everybody has heard of and so many people have experienced, and it is an inflammatory disorder of the pilosebaceous follicle. The sebaceous gland contiguous with the hair follicle, we could say. And it occurs most commonly during adolescence, at the time when teenagers are going through a lot of hormonal changes and their body is starting to produce and release more oil. It involves the sebaceous glands that are commonly located near hair and where they release that oil, and during adolescence they start to become more active, and they can almost become overactive and create obstructions. And the obstruction can allow for bacteria to proliferate, to grow and proliferate, and form these lesions that we know as acne. Now, eventually the body, in most cases, will learn to balance out these secretions to reduce the incidence of acne. If not careful, especially in those that suffer from really bad acne, the bacteria can spread underneath the skin to other areas, which can become quite a problem. Furuncles and cellulitis is our next topic. And they're not the same thing. Furuncles are also known as boils, and they are inflammations of the hair follicles, and it happens usually in one place, and it oftentimes involves bacteria. So somebody could have a small injury to the skin, and then they could be predisposed to the development of a boil or a furuncle, and it's most commonly Staphylococcus aureus that is the pathogenic bacteria that is involved. Sometimes these furuncles need to be drained, which you could probably imagine looking at this image. And if they're not drained, if they're not treated with antibiotics, then they could progress. And if they do progress, that's where we could end up with cellulitis, which is not really inflammation of cells as you might think based on the term, but it's inflammation and infection of the dermis and the subcutaneous tissue beneath that. So remember, we have the top layer of skin is the epidermis, beneath that we have the dermis, and then we have the subcutaneous or hypodermal tissue. Furuncles are not the only cause of cellulitis, but they can be the cause, which is why they're linked on this slide. So here we have the examples of furuncles, and then on the images beneath, we have examples of cellulitis. Furuncles can progress to cellulitis very quickly, so they're important to monitor. And then if cellulitis occurs, this can be a problem because then it could lead to sepsis, where the bacteria enters the blood, causing bacteremia. Impetigo is a superficial infection of the skin, frequently caused by Staph aureus or Streptococcus. And it can occur in adults, but it more commonly occurs with children, partly because children are constantly touching their face, and you could have a child that has very chapped lips that become very bad during the winter months, and then the chapped lips open up and they could end up contaminating the area with bacteria. And this is, although it starts local, it is very aggressive and it can spread very quickly. So you could have let's say it's only in this one region here. If the child has a cut on their face over here and they touch this infected lesion and then touch here, then it can infect that area very quickly, but it can also spread. So this lesion here may have only started as a small area, and then it can spread quite quickly. Sometimes topical antibiotics can be effective in clearing this up. Other times, to keep up with the aggressiveness of it, oral antibiotics are needed. As I said, it more commonly occurs in children, but it can still occur in adults. If you have an adult that is wearing a face mask, let's say for maybe a football mask, a cage for helmet with a cage for sports, and if there's any bacteria within that area and it gets into an open wound on the face, and then if this person, let's say it's a male, they go home the next day and they shave their face, they can spread it to other areas quite quickly. But once it's identified, it's pretty easy to treat. Okay, those were bacterial infections. Now we'll look at some viral infections. Viral infections are very common, and they're more of a problem because they hang around in the body, and they can become active, and then they can seemingly go away and then come back out again. Skin infections with Herpes Simplex virus are commonly caused by two types, type 1 and type 2, so herpes simplex virus 1 and herpes simplex virus 2, and they can affect multiple areas, including the mouth and the genitals. This here is showing you what you would know of as a cold sore, and what I'd like you to make note of is that most oral herpes simplex viruses are caused by herpes simplex virus 1. Most genital warts, herpes simplex virus, are caused by herpes simplex virus 2. And we've looked at genital warts when we spoke about reproductive disorders in Patho 1. Herpes tends to has this preference for neurons and the skin, so it seems to preferentially infect the neuroectoderm. These vesicles, so the term vesicles is being used, they're very painful and they're full of the virus. And so they're very contagious, and somebody with a cold sore can easily pass on that cold sore to somebody else. And then once they do, then that person will have that virus for life. And you can see that it also infects the mucous membrane, and it's probably up here in the nose as well. Herpes can become dormant, as you probably know, and then it can become active again. So those that have cold sores, and there may be many of you that have suffered from this yourself, you know that it tends to come out during times of immunosuppression. Maybe you're very stressed, maybe you're sick, and your immune system is suppressed, then these cold sores tend to rear their ugly head. So now we'll look at herpes zoster. Herpes zoster is also known as shingles, and if you work with elderly patients at all, this will become something that you see quite frequently. And it's caused by the same virus that causes chickenpox, which we'll look at the next slide. So that's the varicella zoster virus. Now, when someone has chickenpox, so herpes varicella, the infection will clear up, but then it remains as this latent, latent in trigeminal and dorsal root or sensory nerve ganglia. And when someone's immunity declines, so for example, they could have chickenpox as a young child, and then maybe when they're 60, their immune system is suppressed to some extent, then this virus can become reactivated. And when it becomes reactivated, it doesn't cause chickenpox, it causes herpes zoster. And so the presentation is different. The initial symptoms will be pain and paresthesia that is localized to the affected dermatome. Remember, a dermatome is the cutaneous area or the area of skin that's innervated by a single spinal nerve. And then it's followed by this vesicular eruption along the dermatome. So it could be the facial dermatome, cervical dermatome, or thoracolumbar, so thoracic or lumbar dermatomes. The lesions frequently do not cross the midline, but they can wrap around from the back to the front of the individual. And it's very painful. There's no cure for this. Antiviral drugs, though, can be used within the first 72 hours to help reduce the severity for the person. And the lesions themselves are very contagious. So let's say we have a 60-year-old man that has shingles or herpes zoster, and he has these vesicles that contain the virus, and he comes into contact with a young child who has never had chickenpox. This young child can then get chickenpox from being exposed to the shingles virus, because we know that they have the same virus. They just present themselves differently depending on whether it's the first exposure or if it's being reactivated. Okay, now we'll talk about measles, rubella, and chickenpox. Viral infections such as this are more commonly seen in children. These three are similar in a lot of ways clinically. They all cause fever, erythema, and localized macules or papules that are red. There can be a slightly different distribution between these, and I'll go over some of the major differences. Let's start with measles. Measles also tends to affect the mucosa. So if somebody a young child has a rash that is suspected to be either measles or maybe rubella or chickenpox, sometimes looking at the mucous membranes can help determine what virus they're infected with. And this condition is not seen as much anymore because of vaccinations, but you've heard of many cases that have come up, and in most cases it is something that clears itself up and doesn't leave any lifelong problems, but it does infer lifelong immunity when people experience measles. But in those that are immunocompromised, it can become a big problem and cause major lifelong problems and can even cause death. So it's the immunocompromised people that are more prone to problems that come out of measles, just like they are with other conditions as well. Moving down to the bottom, chickenpox. We spoke about that on the previous slide. It's also called varicella. So if we go back to the previous slide for a moment, it's called varicella, that's the chickenpox, and then zoster is the shingles part, so the same virus. With this, the papules are more pronounced and they contain vesicles, and these vesicles are what is within them are very, very contagious, and they're very itchy. Chickenpox usually doesn't yield any long-term problems in majority of cases, and in most cases the worst outcome is that because the person is scratched so much, they end up leaving some scars on their skin that become lifelong. But that's just cosmetic. Chickenpox isn't seen as much now because of the chickenpox vaccine, but for example, when I was young, everybody had chickenpox. I didn't know any, it was rare for me to know someone that did not have chickenpox. And that might be the same with many of you. But when I was young, when one child got chickenpox, it was very common to host or go to chickenpox parties so that all the kids could get exposed to the chickenpox virus and sort of get it out of the way, because it's less of a problem for children or at least it was thought to be less of a problem for children and more of a problem for parents having to take the time off work when the chickenpox goes from one child to the next in a household. But that's not something that's recommended or seen nowadays. And finally, rubella, also known as German measles. This is sometimes called 3-day measles, and it tends to first be a problem in the face and the trunk in terms of the distribution of the rash, and then it progresses outwards to the limbs. But in all these cases, the rash can be itchy, but with chickenpox, it very contagious what's within the vesicles. With conditions, for example, measles, that can be spread by a runny nose rather than from the rash itself. Okay, let's finish off our lecture talking about fungal infections of the skin. And on this slide, what we're talking about is collectively called tinea, which is a Latin word for worm. And then the second word in each case, pedis, capitis, and corporus, refers to the location that fungus infects. Fungi are not very virulent, so they're not very aggressive. They tend to be superficial, and so they can be called superficial mycosis, referring to the fungal infection. The first one, tinea pedis, is also known as athlete's foot, which you probably heard of, and it damages the epidermis, causing the scaling of keratin that you can see. And it's difficult for the body to treat this condition, or difficult for the body to fight off this infection, because the epidermis, remember, is not vascularized. And this condition is superficial and tends to infect the epidermis. And so our immune system, for example, neutrophils, they can't really get to this area to clean up the infection. So local treatment with antimycotic creams or antifungal creams are commonly used. Tinea capitis, this is also known as scalp ringworm, and this can be caught from animals, from cats and dogs. And tinea corporis, same thing. Corporis means body, whereas capitis meant head. And tinea corporis, this is the ringworm that you usually see, and it can also be caught from cats and dogs as well. So if you have children that are playing with animals that have this fungus, then it can be passed on and infect their skin. It tends to preferentially affect the non-hairy parts of the trunk, the face, and the limbs, and it has that very classic ringworm appearance to it. So there are different fungi that can cause each of these different conditions, but we're not going to be getting into the detail. But being able to look at these conditions and where they tend to affect can help with diagnosis. And our final condition is thrush. Thrush is a term used to describe the presence of Candida albicans, and so it is commonly called candidiasis. And this fungus will affect primarily the mucous membranes of the mouth of infants, which you can see here. You can also see it can affect the nail beds, and it can affect areas such as under the armpit or in the groin where there are those folds present. Now, with this infection, it attracts neutrophils to the skin site, and the problem is the neutrophils are not able to do what they need to do. The fungus can evade the neutrophil job of killing. It's characterized by the formation of these white plaques or spots that can end up leading to shallow ulcers and can be quite uncomfortable. The tongue may have this very dense white covering, this dense white layer that covers the mucous membrane. But what's important to note is, because this can be seen quite often in infants, if an infant has this white coating on their tongue, if it's scraped off and it is in fact thrush or candidiasis, then the underneath part, underneath the white covering, so at the level of the mucous membrane, it would be very red and very tender and can bleed when there's that attempt to scrape off that white covering. And so that if that happens, that can be a good indication that it is in fact thrush. Another important consideration is that a baby that has thrush can pass this on to a mother and infect a mother's nipple with breastfeeding. Fever and gastrointestinal irritation are common with candidiasis. This infection can spread to the groin and can spread to the buttock as well, so to the skin of the groin and the skin of the buttock. It is more common in immunosuppressed individuals. It's also more common in diabetics that are not controlling their condition very well. And so if thrush is suspected, then thorough examination is important, looking at different folds in the body. If you have a diabetic if you're assessing a diabetic that has very poorly controlled diabetes, a thorough examination would include looking at their nails, looking at their mouth, and looking at the different folds of their body to see if this fungus is present. Okay, that's the end of today's lecture. Thank you for listening.